All right, guys. So for those of you that have watched some of the other lectures, this one's going to be a little bit challenging. I just recorded like 15 minutes of it, and I kept making so many stupid mistakes that that I had to stop and start over. So it might be the same way. The reason is that I've been dealing with a cold, and I don't know what it is exactly. But last night I took some NyQuil because I'm a huge baby. I'm the kind of guy who gets super dramatic when I get a cold. And so I'm like, oh my gosh, I'm gonna die, and work is gonna be so hard. Blah, blah. So I took some NyQuil, and that makes my brain like mostly shut off. So not only is it Monday when I'm recording this, but it's also post NyQuil haze Monday. So this is gonna be maybe a little bit rough, but that's my excuse. I know I always leave excuses at the beginning of these lectures to explain why it might be weird or whatever, but that's my excuse for today. So. Just so you know, if I act a little bit goofy, that's why. But today we're going to talk about traumatic spinal cord injury. Just a few things to start with. According to the text, most of the common causes are motor vehicle accidents, sports injuries, falls, work-related injuries, violence, that kind of thing. Although it can happen from anything. This is just sort of the common ones. A little bit of the basics is that most of you are probably familiar with the way the spinal cord works. The brain is the central nervous system, and it moves sensations up and down from the body to the different varying limbs or whatever. So the lower the level of injury means that the less severe the injury will affect a person afterwards. So, we'll get into the details of what that means, but just that's kind of the basic thing. Is that the lower the injury, the more it's going to affect the lower extremities or different parts of the body. And then this can be kind of confusing for people that haven't learned about this stuff, but a completely severed spinal cord will mean no sensation below that. However, a damaged spinal cord might mean sensation, but just altered functioning or altered sensation. So that'll become clear as we go through the varying levels of varying vertebrae and the injuries at that level. But it's confusing for people sometimes when you say like, well, I had a cervical injury and I'm technically tetraplegic or quadriplegic, but I can still use my hands and I can feel certain things and that kind of thing. So there's a lot of nuance in what the injury means and how it affects a person. Just some basic terminology. You'll hear the word paraparesis, which means that there's going to be some level of functioning below the level of injury. And that, again, goes back to this idea of if the spinal cord is completely severed, that means that there's going to be no functioning, but paraparesis means there's going to be some if it's just an injured spinal cord and just like, slight damage to it or something. Most of you are familiar with the term paraplegia, paralysis of lower extremities. The two bottom terms, tetraplegia and quadriplegia, are kind of used sort of interchangeably, but it depends on the setting you're in and who's talking about it. And the reason this is important for the counseling world is that apparently it's the medical community who prefers the word tetraplegia, and it's kind of a relatively new thing. So if you have older physicians or older healthcare professionals or whatever, they still might use the word quadriplegia. But apparently the new term is tetraplegia. That's the most kind of PC term. You might still have people who prefer the word quadriplegia, especially in the disability community, if they identify as, like, some people use slang terms to call themselves and their friends, like you hear terms like the quad club or something like that. And sometimes people just prefer that because that's how they identify. That's a meaningful thing. However, if they've had experiences where quads have been used as kind of a pejorative term, it's not a, you'll hear sometimes people like say, well, he's a quad, which is kind of has this negative connotation to it, in which case somebody might prefer the word tetraplegia. So it's always important to ask, of course, who the person is and how they identify, because then you can use the term that doesn't make them feel like they're being reduced to a condition, something like that. So just be aware that those are two kind of sort of interchangeable terms, but they're not necessarily interchangeable. It just depends on who you're talking to. Oh, and one other thing too. I've mentioned before the quad equina syndrome, and that refers to injuries below the level of the lumbar, but also the sacral spinal column parts too. And what that refers to, again, is it's a syndrome related to the nerve fibers that come off of the spinal column, but we're not going to go into detail, but I just wanted to make reference to that because you'll hear that quite a bit. Well, I don't know about quite a bit, but you'll hear it sometimes, I guess. Okay, let's talk about the varying levels. So The cervical level here, we're talking about what we see in blue up above, maybe blue and purple. Was that purple? Blue, dark blue, purple, whatever that is. Uh, in terms of diagnosis, C1 through C8, if there's an injury to the cervical level, that's when a person is diagnosed with tetraplegia. Below that is going to be a diagnosis of paraplegia. C1 or C2 levels is the higher levels. Those can be potentially fatal because that's damage to basically the brain stem or close to it. So those can be potentially fatal. C1 through C4 level will affect respiration. A person may or may not be able to independently breathe, but oftentimes you'll hear labored breathing. I have a friend who has, I don't know exactly what his level of injury is, but when he talks, he'll sometimes have to stop and take a breath. It's kind of like when I walk upstairs and try and talk to somebody, like the classroom that I go to is up one flight of stairs, and sometimes I'll be having a conversation. I'm hopping up the stairs and I'm like, oh my gosh, am I just out of shape or what? But when your body is moving, you're trying to do active things, you're requiring to use your lungs more, and have conversation, it could be challenging. And this is sort of a common thing with people with spinal cord injuries where their lung muscles may not be as strong, and so they're working harder to breathe as well as communicate. So they might take more time to communicate with as a result. At this level of C1 through C4, a person will likely require assistance for self-care. However, they may still be able to use a wheelchair. Oftentimes there's all kinds of different ways in which people do this, but like a mouth stick or a blow stick, or using some sort of assistive devices, they can still operate the wheelchair by themselves and ambulate around their environments. At C5, there might still be some gross motor movement of the upper extremities, and at C6, which is a little lower, may still be able to do some self-care, including using a manual wheelchair. And this is where it gets kind of challenging for people if they say, I have the diagnosis of tetraplegia or quadriplegia, but I still could use a wheelchair with my upper arms. It's because they're still functioning, but they don't necessarily have all full functioning of grip and strength and all that kind of stuff. But I could still use the palm of my hand to push the wheel on the chair to get around. So that's still a potential possibility. At C7 level, that means I still might have some core body strength to like sit myself up in bed, straighten my arms, even though they might not have full functioning. I might, be able to do this kind of thing. I could still get dressed and potentially transfer. Transfer meaning like move out of my chair onto a bed or onto the toilet or something like that. And at level C8, I might have some sensation in my hands and become totally... the spelling error may become totally dependent with modified environment. By the way, if I haven't told you the story already, when I was in second grade, I lost a spelling bee because I misspelled the word mother. And ever since, I think it's just like psychological trauma that's like either I'm just never was meant to be a good speller, or the trauma has led me to just be a terrible speller ever since. I think this one's just a typo, but I still suck at spelling. So if you see spelling errors, you can point them out. That's totally fine. I will just hide behind another one of my excuses, like saying I can't spell the word mother. I've told this story in class before, but I was in front of the whole entire school. I was like the top speller in second grade of all like 15 people in the class or whatever. And I wrote down on my paper, you know how they say at spelling bees, they're like, spell the word mother, and then you get a little piece of paper and you write it down. I spelled M-O-T-H-E-R. And I look up and I see all the people and I kind of freaked out a little bit and I said, mother, M-A-T-H-E-R. I totally spelled it wrong and they're like, that's incorrect. And I was like, what? I looked down, it was right, but I screwed up. Anyway, and then a kid made fun of me on the way back to class. So ever since then, I'm like, I suck at spelling and I hate it. Whatever. Okay, no more excuses. At the thoracic level, T1 through T12. This is the biggest part of the spinal column. Let's go back to our picture. This is the green part. See right up there? A T1 or lower means upper extremities are unimpaired. Let's see. Let's find our picture. So upper extremities are mostly at the cervical level. That's where my arm functioning comes from, basically. So if it's lower than that, that means that I'll still have function of my arms, still have maybe some impairment of, as you see here, T1 through T3. Excuse me. There might be paralysis of trunk muscles. So I still might have a little bit of trouble breathing. I might need a brace to sit upright in a chair or something like that. But I probably will not have as much functioning of my lower body. Thoracic injuries mean almost total independence with modifications of environment. So I'm still going to be able to get around and do most of what I need to do without assistance. In other words, like a personal attendant or something like that. And at the T7 through T12 level, I may be able to walk for some short distances with leg braces. Now, that doesn't mean that somebody won't need a wheelchair. Doesn't mean they're not going to be able to walk fully for long periods of time. It just might mean I might still be able to get around for some amount of distance. It just depends on how much. So there's a lot of variation with that, of course, because just individual circumstances. The lumbar level, so this is sort of like the lower back level. This is where you're going to see a lot of people with like lower back injuries relating to like sitting, and work-related injuries are more like this kind of thing. Upper body and some leg muscles remain functional. This is where you're going to see a lot more like pain. We're talking about things like the opioid epidemic and people getting medications and stuff. There's a lot of lumbar injuries like this that are leading to that kind of thing. Ambulation with cane or crutches may be possible. By the way, it's worth mentioning here that this chapter is talking about traumatic spinal cord injuries, like a single event. And that's kind of what we put in our mind. But when it comes to understanding spinal cord injuries, it's not just a single event trauma, but like over time sitting injuries and stuff. So I'm kind of lumping some of that in here too when I talk about things like work injuries and, pinched nerves and all that kind of stuff. So anyway, I mentioned this before, but ambulation with a cane or crutches may be possible, but still I might need, if I'm going to go shopping or walk around a zoo for 5 hours, I'm still going to need some sort of either time to sit and rest, or maybe a wheelchair to get around in those situations, even though I can get up and walk. And this is one of those like social stigma related issues of somebody might be in a wheelchair and then stand up, and then if people around are like, what is it? I'm so confused. But like, this is where like the nuances of, I might need a wheelchair to get around for longer periods of time, but I can get up and do some things. Sometimes you'll have people who are like, I just don't want to deal with that because it just like people are so weird about it that I'd rather just sit down and not get up. I'm not going to challenge myself to move and walk because people are going to stare and ask dumb questions like this kind of thing. So you'll get people who shy towards sitting more often because of that kind of stuff. However, if somebody is more assertive and can explain that, that kind of thing, but it's just, this is where it gets really confusing for other people. If you have injuries to the lumbar level, bowel and bladder functions are still affected somehow. So that might mean that I might lose like voluntary ability to evacuate bladder or bowels, but I might still have some functioning of it. So it's just, I might have accidents or that kind of thing, maybe a little bit more often. At the sacral level, this is sort of like down underneath the butt crack, right around there. The bowel and bladder may still be affected, but I might be able to regain complete pre-injury function because of the way that the nerves are in there and the lower portion of the spinal column. If I break a vertebrae down there, it might not mean that it's permanent injury or damage. So that's worth mentioning. Okay, let's talk about the physical implications. Pulmonary functioning is affected. I already mentioned about ventilators, how they might be required, and about the labored breathing. So the other thing about that is that if I have a hard time, if my lung muscles have a hard time, one of the primary functions of my lung muscles is not just to expand and contract the lungs, but also to cough. So if I can't cough, get out all that gunk, like phlegm and stuff out of your throat, then increased liquids or increased moisture, all that kind of stuff can stay in there and create potential for infections or pneumonia, stuff like that. And so It might be that the pulmonary function affects my, psychosocial ability to communicate, but it might also lead to a medical condition like pneumonia. And so it's important that that those things are treated or paid attention to. Ambulation, moving around, of course, I already mentioned that. T12 or higher people requires a wheelchair. The lower still may need access to one. We're going to continue the physical complications for a few slides here, by the way. Bowel and bladder. So let's talk about these for a little bit here. Most people with almost any level of spinal cord injury, or I guess you could argue that any level of spinal cord injury, will have some changes in their bowel and bladder functioning, the ability to control it. That's basically what I mean. In which case that we need some sort of routine, or like be really intentional about when and how do I go to the bathroom. For most of us, our body can tell us, like, okay, it's time, right? As with little kids, we say, like, you got to get used to learning how to feel your body and understand when it's telling you that it's time to go to the bathroom. However, if that sensation is lost, just like when you go on a road trip with a little kid and they're like, I don't have to pee, and then 5 minutes later you get into the car and they're like, I gotta pee, and you're like, you're supposed to tell me this stuff. Hopefully we're not getting frustrated with them, but in the same way, with an injury, you might have to say, well, maybe I should pee before I get in the car, or maybe I have to set a schedule so that I know every hour, every 4 hours, every 10 hours, whatever it is, probably not 10, but on a schedule, I'm going to take care of this part of my daily needs so that I don't have to worry about getting in the car and then 5 minutes later I'm like, I gotta go, right? It's not quite that, that's kind of a silly story, but it's more like, if I don't pee on time, then I run the risk of having some sort of urinary or bowel accident, which can create not just issues like potential skin breakdown, it's like inconvenient and intrusive in your life, but also can be really embarrassing for people. So this becomes a really, really important part of not just a person's medical care, but their psychosocial functioning as well, and that sense of self-concept can be really hindered if somebody has those kinds of things and they're not able to take care of this on a routine way. So just a little terminology again. Neurogenic bladder refers to the inability to voluntarily empty the bladder. And there's a few different options there if somebody can't do this. One of them is called a condom catheter, or also known as a Texas catheter, which is basically a cap that goes over the penis with a tube in it that goes down to a bag. And that just allows for, whenever a person goes to the bathroom or has sort of, I guess you could call it leakage, but it's not necessarily leakage in this case. But when their body just pushes urine outside, then it goes into this bag and it's just taken care of that way. I imagine, have you ever heard of, I don't know if this is true, but if you ever see anybody filibuster in Congress when they're just talking and talking and talking for hours, I would be really surprised if they didn't go into that wearing something like this so they wouldn't have to deal with going to the bathroom. Or situations where people are like on long road trips or something. I don't know, but I just imagine people using this kind of thing so they don't have to stop and go take a restroom break or whatever. But that would be an example of it. An indwelling catheter means it goes through I don't know why I can't help but giggle when I hear this word, but the urinary meatus. A meatus just means opening. And basically what that means is the pee hole. So for men and women, it goes through the urethra up into the bladder. And that just, it then negates the need to put something over the body. They can tend to fit a little better, but putting things into the body that are foreign objects creates the potential for infection. So there's increased risks with that too. So, but it's an option if it needs to be one. I think this mostly, the determination of when and how to use this has a lot to do with, does it make sense for a person? Is it going to actually work? And there's lots of considerations that go along with that. But there's also the suprapubic catheter, which means a surgical insertion into the lower abdomen that can go right into the bladder, kind of over the top of it, that kind of thing. And then bowels. In order to allow for bowel movements, because a person can't feel when they have to go to the bathroom, they have to do this on a routine basis as well. but there's not really an option for, I guess a person could wear a diaper or something like that, but those are still really inconvenient. And the better option is to say, if I go to the bathroom, I need to find a way to evacuate all my stool on time. And so the options there are suppositories, which is just like a little pill that goes into the anus. Small volume enemas is an option, sort of flush it out. Or digital stimulation is also a thing that some people need to use, which is just, a finger inside the anus to sort of move things around and get it flowing, and then it comes out that way. Dietary, I don't want to call them restrictions, I guess, but dietary considerations are also really important here. High fiber diets are good because it helps create consistency in the stool, and so it can, come out easier. Most of us understand this. You've had situations where you're not eating high fiber. It's messy and difficult and all that kind of thing. Avoiding gas producing foods is pretty important because, by the way, if you haven't seen one of these lectures before or watched the recordings, I try to put this stuff in sort of plain language that most of us can understand. Like using words like pee hole makes more sense to people than urinary meatus. So when I say avoiding gas producing foods, because most people have had the situation where you feel like you have to pass some gas, and it doesn't. There's more involved than just air in that situation. So in other words, if you're eating high gassy foods, it's a SHART risk. Most of you know what that means. Adequate hydration. Constipation can be a risk, especially if they're taking medications, which many people do and have to for certain conditions. And constipation is it seems like it's almost always one of those side effects that affects people. So maintaining hydration with a spinal cord injury can be important, not just as a as a good thing for the body, but it can also really help this bowel issues. Sexual functioning. So here's another important topic. Even if sexual sensation or functioning, like the ability to produce lubrication in females, the ability to have an erection in males, that doesn't mean that attraction or sex drive or the desire for a partner, that kind of thing, doesn't mean that changes. And so this is where that sort of self-identity conversation comes in. We're not going to have that much today, but maybe in class we'll have that, or at a different day. For males, what this might mean is reflex erections may still exist. So it's really common for guys to have erections at night, and even during the day sometimes just sort of like happens, especially in teenagers when people are going through puberty. They get these reflex erections that, no matter what, you sit down the wrong way and you're in junior high and all of a sudden, just can't help it. But you still might be able to manually stimulate the penis in order to have sex, if that's what you're going for, or, whatever. Oftentimes what's affected is the ability to be psychologically aroused. And so that's the kind of what sometimes cannot happen. But however, with manual stimulation, that means that somebody with a spinal cord injury can still be intimate with the partner and still have most functioning and the ability to have sexual intercourse. But it might not come from just the thinking alone and the sort of, that's enough said, I guess. Another option for people that aren't able to have erections is that they still have that sex drive and they still want to have sex with their partner. Penile implants that work kind of like with a pump that can be implanted into where basically the blood flows into the penis and sort of fills it up. Those can be implanted with pumps, and you can just Google it and see what they look like. It's kind of interesting. But that can be an option. So you can kind of like pump up the penis, sort of, if anybody remembers from like the 90s when you had those little shoes with the little basketball on the tongue of the thing, and you pump it up and you can feel like your feet squish. I don't know. It's been a long time since I saw this, but they're kind of fun. But it's kind of like that. You just pump it up and then you can do your thing and release it and, go on with life. Another option for people who do want to have children is electroejaculation, meaning electrical stimulation. I don't even know what this looks like exactly, but like I imagine some sort of like vibrator kind of thing can help a person ejaculate. The sperm can be collected and then artificially inseminated into the partner for conception. So those things can still happen. In terms of female implications, reduced lubrication is a common thing with lots of conditions. So it's not just spinal cord injuries. but that's one that gets affected here. So the simple use of a lube, to use the common term, some sort of jelly or whatever, can solve this easily, and that may not be a big issue. It's just sort of a common thing. Contraception will still be important because even though the nerves may have been damaged, all the other parts, the insides, may still work completely fine, which means pregnancy is still possible. One of the challenges, though, is that it may be difficult to determine when labor begins. So you still have a child and carry to term, but you might not feel all the same sensations. And when it comes time to go into labor, that might be some extra considerations to think about when and how that happens, like a scheduled birth. Can still be possible to have a vaginal birth, but depending on what's going on, C-sections might be a better option, or at least a scheduled labor delivery, that kind of thing. Okay, first of all, before we go any further, I wanted to show a picture of this halo thing because, well, I guess I'll say the first one. Initial management of this is just about stabilizing physical condition and managing all the physical symptoms that go along with a traumatic body event. And a halo vest might be necessary if it's a cervical injury or even thoracic injury potentially. But I took these pictures off of Google because I thought they were funny, because I first saw this one above there and the guy's expression is so flat that I was like, huh, that's really interesting. And then I saw this other one where he's got this funny smirk on his face. I can't tell what he's doing, but he just looks kind of awkward. He's like, So I got a good chuckle out of that. So I wanted to include both pictures just because I thought it was funny. Excuse me. And then post-acute management. So once the person is stabilized and they maybe have this on, or if they don't require a halo vest, once they're stabilized, they can go on to do things like, I can relearn certain skills. I can learn about assistive devices that are going to help me function. Sometimes assistive devices are going to be needed permanently. Sometimes they're used only temporarily. But I'm going to start doing things like PT and OT and engaging in speech therapy if necessary. This is also when counseling can happen with patient or family. This is when rehabilitation counseling can kind of begin, thinking about vocational futures and that kind of thing. Typically, I think vocation doesn't quite start this early usually. However, all vocational counselors, I shouldn't say all, but many vocational counselors would say the earlier we can start it, the better, because vocational counseling is not just about wait till you reach maximum medical improvement, or a lot of people use the acronym MMI, which means maximum medical improvement. But rehab counselors know that a person's self-concept and their self-esteem and all these things are so intricately tied to their person's working life and their work identity that the earlier we can do that, the better. However, it just doesn't happen that way, I think, in most situations that I've heard about it. So, but that's kind of when we come in. Okay, let's talk about complications. There's going to be a bunch of these, and some of these I'm going to go through kind of fast. Some require a little bit of explanation if I haven't gone through the terms yet in the class. Oh, by the way, I'm just having this moment of like second guessing myself. I have not worked in an acute rehab facility like this. This is not my specialty. However, I've been around enough of this stuff, and I know I've learned enough about it. But some of you may, if you're watching this, you might think that's not necessarily true. What is this guy even talking about? Some of this stuff is not. These are not things that I know a ton about. And so if you have other experiences with these things, absolutely share that with people and tell everybody. I wish I could hear from all of you right now and hear you say like, no, it's more like this. And so it just might be the case that's what you might have, that experience of like, these things are different actually. It doesn't work that way, that kind of thing. So pressure sores, also known as decubitus ulcers, that's kind of their technical term. When the bone presses on the flesh, it cuts off circulation, which means, in other words, it's ischemia. We talked about that in the stroke chapter. Like an ischemic attack means the blood supply has been cut off. If a person can't feel pressure, they can't tell when they're like uncomfortable and sitting on a place too long. And so it leads to these little ulcers, and they just look like little kind of red marks at first, and they kind of open up, and then they can get bigger, and they can be a big deal and hugely problematic if not treated. They might look small on the surface at first, but underneath is where the tissue damage really happens. In the book, they talk about necrosis or skin death. And it's not even just skin death, it's like underneath the skin too. These can be, they're easily treatable. So just an example, I know a guy who's in a wheelchair, and his wheelchair will rock back and forth periodically, and the whole purpose of the rocking back and forth, it's like, every like, I don't know, 10, 20, 50 minutes, I don't even know how long it is, but the whole purpose of that is to change the pressure on different parts of the body, and it just automatically does this for him. It changes pressure on different parts of the body so that he doesn't have this happen. And it's one of those things that if a person is moved around or can move themselves around, or depending on how much movement they have, it's easily treatable. However, this is one of the most common things that people show up in the ER and say, "Hey, I have this problem. It hurts," and even if you can't feel it, like you can tell there's something going on down there. And it's usually on things like the legs and the butt and the back, depending on where a person is. So really avoidable, but also, people go to the ER for these kind of things because they aren't treated or taken care of, which means we're not doing a good enough job educating people and helping them understand their conditions and secondary complications. I've used the word sequela before. Ulcers are a sequela of a spinal cord injury. Complications, I guess all this stuff is. Spasticity, we mentioned what that is. That's like the shaking caused by increased muscle tone. It can be embarrassing. It can be incredibly painful for people. It can be tiring, just exhausting on the body to be kind of like managing that shaking. It's just like, imagine flexing for a long time and then all of a sudden your arm feels tired. It's kind of like that. It can disturb sleep, so hinder a person's ability to stay asleep if they get asleep. It could also contribute to contractures. Imagine if you're like, the increased muscle tone, I've described it as like just a constant flex. If your arms are at rest, you can still move them up and down. It's not like they're totally flaccid, but you can, have a good range of movement. But if they're constantly kind of flexed, they're a little more rigid. They don't have as much movement in them. So increased spasticity can mean less movement of the joint or whatever part it is, and that can contribute to contractures or reduced flexibility and range of motion in the joints. This can be, in regards to contractures, this can be especially challenging if they happen in the hip or the knee, because that can decrease the ability to position in a wheelchair effectively, or in a way that's sort of comfortable, or helps a person function in their best way. Chronic pain. This is kind of an interesting one. Here's a couple points about it before I get into too much, but can be debilitating, absolutely debilitating, above or below the level of injury. So changes this is one where, most of the time you decrease functioning below the level of injury. This can be one where you can have pain above and below injury. Part of the reason for that could be that, think of something like spasticity. If below the level of injury is spastic and moving around, I'm oftentimes compensating with other body parts or moving. Another reason might be if I am unable to move my legs and I'm in a wheelchair all the time, that means I'm using my arms more. And so I'm using them in a different way than they weren't evolutionarily designed to work. And so it might change the way I might have more pain just for the use of my arms, that kind of thing. If I have a hard time slumping over and I'm turning my neck like this to sort of keep my head upright, not a hard time slumping over. If I'm having difficulty with my posture and I slump over, I'm going to be, using my neck differently. So just all kinds of things can affect this, the level of pain in the different places in the body. The term neuropathic pain is unrelated to those things I just said, and it just says like it's an atypical processing of sensory information. So we're going to talk about autonomic dysreflexia in a little bit. It's just like mix up of signals. My body is like, I don't really know what's going on here. And so it sort of sends messages in the brain that there's something happening that shouldn't be, which is kind of what pain does for us. It tells us that something's not right. So there could be pain from a legitimate reason, because like my neck is tilted this way, or it could be that it's just like a mix-up of signals, something like that. So pain can happen in all these different ways. Um, it can be treated sometimes with medication, although we're still trying to figure out how to do that without creating secondary complications like addictions with opioids and that kind of thing. So we're struggling with this pain thing right now. Some people use alternative methods like acupuncture, massage, homeopathics, and at the bottom here, where medical marijuana is probably more of the conversation now in terms of how a person copes with their own pain. And basically, I probably should have had this second to the bottom one at the last, but we don't always know how to manage pain. It was interesting reading the book, and they said, like, there's this thing or that thing, but we don't really know, you know? I mean, it's just one of those things it can be so debilitating and so frustrating for people, and it can affect your mood, irritability, all that kind of stuff. Your ability to do activities of daily living and have romantic relationships with your partner and go to work, and all these things can be affected by it. And yet we struggle so much to figure out how do you deal with it. And so there's all kinds of different treatments that are available. But the question is, which one's going to work? Which one's going to actually help somebody? And there's not a lot of consensus about which ones work. I mean, you could smoke crack and it would take away some of the pain, but at what cost? You could take opioids prescribed from a doctor and it'll take away the pain, but at what cost? You could go to you could take homeopathic remedies, but at what cost or at what benefit? Like we struggle with this one so much, and not just with spinal cord injuries, but lots of them. All right, this is going to be a whole bunch of terminology here. Cardiovascular complications, or blood circulatory system complications, thrombophlebitis, blood clots in the legs, pulmonary embolism, blood clots that travel to the lungs. These are just complications where blood clots can form just because the body is working in a different way and not as things aren't fluidly flowing through all the different areas as much. And so a stoppage in blood flow in one area can create these quirky things that happen in the blood vessels that could potentially lead the blood to clot. Especially, by the way, if somebody has a bruise or a cut or something like that they can't feel and don't notice, that can be hugely problematic, because if a person doesn't see it happening or notice it happening, and then things like blood clots might form, whatever, and we'll go through some more of these complications, and as we do, you'll see that that issues can happen inside and outside the body that are not the way the body was intended to work, and so they can create these secondary things. These are a couple. Orthostatic hypotension. Hypertension is high blood pressure. Hypotension is low blood pressure. And it basically means, like, if you've ever got up too fast and you got dizzy, that's what we're talking about here. Fainting, if you ever got up and were like, oh my gosh, I can't, then you actually pass out, that's the term for that is syncope. This stuff part of this might be caused by a secondary conditions due to sedentary lifestyle. So it's not just like this hypotension stuff. It might be part of it, but also things like heart disease from if you're not getting up and moving and pumping your blood through your body. Blood clots can be more possible. Unregulated blood pressure is more of a risk. Heart disease can be more of a risk, that kind of thing. So those are all sort of fit in this cardiovascular category. I'm going to check the time real quick. I'm going to go a little faster. Autonomic dysreflexia. The risk is above the T6 level injury. Basically what's going on here is that if you have things like an overextended bladder, it's too full, if you have pressure sores, constipation, that kind of thing, the body says, I don't know what's going on here, something's wrong, something's not working, whatever, and it could be just this sort of like neurogenic complication of like sensory information being mixed up or fuzzed up. Whatever, however you say that. Think of it, the old-fashioned TVs that you can kind of go and turn the knob and it gets a little snowy. You just sort of miss the signal. That can lead to the body saying, oh my gosh, something's not right, something's unregulated. It basically freaks out and says, okay, we have to drop our blood pressure really fast to manage this thing and like compensate for it. And what that can look like is if the body thinks it's overheating, or if it's overheating, they can start sweating, you can get headaches, and all these sort of weird things happen, and it can be potentially life-threatening. So this is a big risk. Um, can be managed most of the time easily if you just follow your bowel bladder program and that kind of stuff, but potentially risky complication, that one. Thermoregulation can be difficult. Basically means unable to regulate body temperature. This is a really common one that I'm not going to say anything more just for the sake of time, but imagine your body says, like, I sweat in order to keep myself cool, and I might shiver in order to heat myself up. But if my body doesn't know when it's cold or hot, or like especially my lower extremities, it might have a hard time deciding when to shiver and when to sweat, so it just does them automatically. So that can be a challenge here. You'll sometimes see people wear blankets over them if they're to keep them warm, even if it's like a warm day out, because their body just needs to know that it's like extra warm if it tends to be pretend that it's underheated or something. Pneumonia and pulmonary problems, I already mentioned that relates to purging out the phlegm and gunk and coughing if the respiratory muscles are weakened. Urinary tract and bowel complications, infections can be a problem because for many of us, when we go to the bathroom, we get as much out as we can, and then it sort of empties the urinary tract and stays in the bladder. But for people that are just constantly sort of going at a steady rate, every so often there's more urine in the system, which means it can lead to more infections. Sometimes if there's a backup of urine into the bladder or into the kidneys, there can be issues with the kidney infections and that kind of thing, sometimes even blood infections. Kidney stones are a risk. Skin breakdown, if somebody is peeing and they don't feel it or don't notice it and it just sits on the skin, that can lead to skin breakdown. If I had more time, I'd tell you a funny story about when I well, I'll just save that story later. If you guys want to hear it, I'll tell you sometime, but yeah, enough said. The other thing too is that this altered manifestation stuff down here, if I can't feel pain in my body, I might have a hard time knowing if I have a tummy ache, or if I have appendicitis and I can't feel my appendix hurting before it's about to rupture. Most of the time I can feel it and get this intense pain, and we go to the hospital and they say, oh yeah, we need to take that out because otherwise your appendix is going to blow up inside of you, which may not happen, leading to bigger risks. Functional implications. Okay, we'll switch gears here a little bit. This is where we get into more of the counseling territory. The altered self-concept and self-esteem, we're going to talk about this with every single one of the conditions we cover in this semester. And we've already talked about it a bunch in earlier lessons, so I'm not going to get too far into this, but this is a hugely important one because it's not so much that, how do I say this? Life satisfaction, I'll just read this next part. Life satisfaction does not seem to be related to severity of injury, but rather how it affects my visions of myself, who I think I am, but more like my life goals and what the meaning in life and my purpose. So if I'm a triathlete and I'm like, this is what gives me satisfaction. I want to win. When I'm 50 years old, I want to have this many trophies on my mantle or whatever. That's my purpose in life, and those are my goals. It's where I find my meaning. And then I get an injury. It's not necessarily that like, oh my gosh, my life is going to be ruined now. It's that the meaning of my life is changing and the purpose of life, not necessarily concerned about the injury. So the severity of injury or the level of injury is not as big of a concern as much as how that changes a person's self-image and their plans for their life and that kind of thing. Maybe that was more, now that I say all that, maybe it was more obvious than what I thought it was. Hopefully that makes sense to all of you. Things to pay attention to: depression, very common, and substance use and PTSD and all those kind of things. Depending on the nature of the injury, those could be more of a concern, or the background of a person. The routine bowel and bladder program, that can be a hugely important thing for medical safety, but also for just a person's quality of life and well-being. Because of those things I mentioned, like embarrassment and having to answer questions if there's an accident, or like the need to stay close to restrooms and that kind of thing, they can be managed a little better with a adequate bowel and bladder program. Time for daily activities will just take longer to get around and do those things. Vehicle modifications, we can cover that in if there's questions about it, but there are plenty of vehicle modifications. So even a person with tetraplegia can drive again if they're able to like push on an accelerator that's tied to the steering wheel or something. Even if they can't push on the gas or brake, those are totally possible. Different various kinds of lifts. Everything from just helping transfer up into a vehicle and then put the wheelchair somewhere, to riding your wheelchair up into the vehicle and then lifting it. Most of you have seen those things on public transit and stuff like that. Learning to handle social interactions. So this can be, in the book they refer to this as like being more assertive to help with awkward people who don't understand things. So remember when I said like getting riding around in a wheelchair and then getting up and have people scoff at you like you don't need that wheelchair, that kind of thing. The more a person can learn to be assertive and help explain their condition, or be assertive to say like, you need to figure out a way to fix the stairs on your business. Otherwise, me and a whole bunch of people like me are not going to be able to come in here. You're not going to get our money. So here's the solution that might help you. Those kind of assertiveness. It can be difficult for people because there's a tendency to get really frustrated, and rightly so. Absolutely rightly so. People can say, look, there's stairs everywhere and I can't get into the place I need to get to. And then people tell me like, oh no, we're accessible. You just have to go back by the dumpster and come in through the back door. Like that's reasonable. So it's understandable that people get frustrated and irritated and angry sometimes. So this like assertiveness training to handle social interactions, this can be the work of counseling. Is like, well, how do you build your internal locus of control to say, I can manage these things without going to these other coping mechanisms that could potentially, I'm blanking on the right word here, but sabotage your own good intentions. I want to help inform people, but every time I do, I get pissed and I tell them how stupid this is. So like being assertive is not necessarily the same as being aggressive, but it can sometimes come out that way. And so this is a lot of where some of the fun work of counseling can happen. Family strain, depending on the nature of the injury. Like let's say somebody was just drunk and stupid and they've been an addict for most of their life and they get a spinal cord injury. You can imagine how the family would be hostile towards that person, or pessimistic, or have increased anxiety. Another situation, let's say a person was hit in a car accident and it was not their fault at all. It can still cause things like anxiety and hostility towards other people, and it just pessimism about the fairness of the cosmos, or whatever it is. Like all these kind of conditions are ripe for counseling, and this is where we can really help out in lots and lots of different ways. Continuing that same activities and participation, planning for structured peer activities can decrease social isolation. It's really common for a person to like their friendships change, their social relationships change. So making sure to like be intentional about building in social interactions can really improve a person's quality of life, especially in the early times right after the injury. Depending on, we've talked about this before, but depending on a person's social capital, or how many people they have as resources to maintain their sense of normalcy, that can be really, really important here. And then sexuality, as we discussed before, we kind of already covered this for the most part, but this sentence I thought was really interesting, and I didn't get time to look at this article. I thought it'd be kind of fun to pull that up, but the quote goes, personal assistance may be required to engage in sexual activities, meaning more than 2 people may be involved in the process. And this is something we talked about in a previous lecture, which changes the way, so much that even something as seemingly just straight medical changes and challenges our values and morals. As we talk about this counseling stuff, and I was just mentioning about being assertive and how we interact with other people and what's appropriate social interaction and all that kind of stuff. And then we talk about things like sex, and we're getting into the territory of like morals and values and all this kind of stuff. It can be really challenging to talk about this stuff because some people think sex is only in the confines of, especially in like, I live in a pretty conservative area and come from a pretty conservative family. I'm not making a political statement, but in the spheres that I spend a fair amount of time in because I'm part of my family, my like parents and grandparents and all that stuff. Part of that environment is sex is a very defined thing by the Bible. It's between a man and a woman. It's only two people, and you only do it under the cover of night when the kids aren't around, or whatever, whatever it is. And this, much of our conversation about sex challenges that, because if a person doesn't have functioning and somebody else there is there to help out with that, in addition to the partner, what does that even mean? And how do, like, for some of us, this might be sort of a mind-blowing experience of like, how do you do that? Is that even okay? And so a lot of counseling can really be about challenging some of these deep-seated values and morals that people have. However, of course, as counselors, we follow the guide of what these people want. Like if I have a spinal cord injury and I say, I grew up in a conservative family too, and there's no way in hell anybody's coming into the bedroom with me, especially if I'm scared that I might poop the bed while I'm having sex, because that's a risk, right? But if it's somebody who knows me and loves me and is my sort of personal attendant caretaker, and they know how to deal with the medical stuff so that my partner doesn't have to, boy, it'd be really nice to have some help with that. Or maybe they're the ones that sort of prep me. They if they help, if they say, okay, let's do your bowel and bladder program right before, so you don't run the risk of that other stuff, and they sort of help with that thing, and then they send you in with your partner to do that stuff. Maybe they help with positioning or something, and then leave the room, or like it can mean all kinds of different things. But it's a really interesting part of this conversation about what our values, morals are, and what's okay, and what's just I don't know. It's fascinating to me. Okay, last part, vocational issues. Because of that thermal regulation stuff, you might have to pay attention to the climate of the work environment. Physical barriers, that's pretty self-explanatory, one's pretty obvious. And then depending on the nature of the disorder, pollution and cleanliness. Also, I don't know if they mentioned this in the book, I don't think they did, but access to resources. Like if I have, an emergency that means I need to get home, and so my personal care attendant brings me home. Is it helpful if I work on the third floor of a building, right? Even if there's elevators. If I'm at risk for other things like seizures, or if I need to get to the hospital potentially, is it going to make sense for me to be in an environment far away from a hospital? So the question that I have is, I tend to see people be, and I could be wrong about this, I'd be happy to hear from other people too, but like, is an urban environment better? Or as ambulance services get better and as medical services get more outside the urban environments, depending on the level of injury, that might determine more about where a person lives and what their direct environment is. So anyway, worth more conversation and consideration, but I'm going to stop it there. And I will talk to you guys again later. By the way, I'm really proud at how I didn't mess up too many things. even though my head feels super foggy from the NyQuil that I took last night. I will consider this a great success. So thanks for hanging out with me. And hopefully it wasn't too annoying. All right, see you later.